Picture this scenario, right? It's 3:00 a.m. The house is completely dark. You're utterly exhausted. Your body is just begging for sleep, but you are wide awake.
Oh, yeah, the classic middle-of-the-night misery.
Right. And why? Because of an itch. But I want you to completely banish the idea of like a mosquito bite or a mild rash. Imagine an itch localized to the absolute most sensitive part of the human body, the vulvar region.
Yeah, that is a whole different level.
Exactly. Imagine an itch so profound, so demanding, that it basically overrides every conscious thought, and it simply will not stop no matter what, intervention you try.
It's a visceral, agonizing reality for a lot of people. And for individuals navigating this condition, that 3:00 a.m. scenario, I mean, it isn't just a bad night, it's a nightly relentless cycle.
Which brings us to the core mission of today's deep dive. We are exploring the medical management of lichen sclerosus, which is often abbreviated as LS, but we're specifically putting a microscope on how specialists manage the severe intractable nocturnal itching in these patients.
And it's such an important topic because it's so often misunderstood.
Definitely. And to figure this out, we've compiled a pretty hefty stack of highly specialized sources.
Right.
We're looking at the official clinical guidelines from the British Association of Dermatologists, the BAD, as well as the British Association for Sexual Health and HIV.
Both incredible resources.
Yeah. We also have clinical protocols from some leading vulvovaginal disorder experts, specifically Dr. Hope Hefner and Dr. Melissa Dahir. And, to ground all this clinical data in reality, we're pulling from lived experiences documented in the Mayo Clinic patient forums.
Which is really crucial because when you look at the clinical data right alongside those real patient narratives, you realize very quickly that nocturnal itching in LS isn't just a symptom that makes you miserable or reduces quality of life.
Right.
It is actually the primary driver of long-term anatomical damage.
Let's focus on that for a second, because we need to understand the stakes before we even start looking at the treatments. Why is the fact that this happens at night so uniquely destructive?
Well, it really comes down to conscious control. I mean, during the day, a patient might experience intense itching, but they can actively suppress the urge to scratch.
Or they can, go apply a cool compress or something.
Exactly. You have options. But when you're asleep, or even just in that twilight state of trying to fall asleep, all those conscious inhibitory mechanisms drop completely.
So you're just scratching without even realizing it.
Yes.
Yeah.
You scratch unconsciously. And that mechanical trauma is just devastating for tissue that is already, compromised by lichen sclerosus.
Because the disease process itself causes chronic inflammation.
Right.
Yeah.
But the violent physical trauma of the unconscious scratching, that's what causes the micro tears, the severe erosions, and the intense fissuring.
Reading through the BID guidelines, it becomes so clear that this mechanical trauma, it isn't just causing a temporary sore. Over time, that constant tearing and healing cycle literally destroys the architectural structure of the vulva.
It really does.
We're talking about, the resorption of the labia minora, the burying of the clitoris, and this permanent scarring that just drastically alters both anatomy and function.
You are physically traumatizing tissue that's already in an incredibly fragile state. So halting that nocturnal itch isn't just about, making the patient comfortable.
Although that's obviously a huge part of it.
Oh, absolutely. But from a medical standpoint, stopping the itch is an absolute urgent necessity to prevent irreversible anatomical loss.
Okay, so knowing those stakes, let's unpack what the baseline defense looks like. Before we escalate to the heavy artillery, we kind of need to understand the foundation of treatment and why it sometimes falls short in the dark.
Right, because you have to start somewhere.
And the gold standard first-line treatment for LS across literally every guideline we looked at is an ultra-potent topical steroid, specifically clobetasol propionate at a 0.05% concentration.
And, the vehicle really matters immensely here. The guidelines heavily stress using an ointment formulation rather than a cream.
I noticed that. And it makes sense, right? Because creams have a higher water content, which means they require more preservatives and alcohols to just remain stable.
Exactly.
If a patient already has those micro tears and erosions we just talked about, applying a cream with alcohol in it is going to cause intense stinging. It's going to burn.
Oh, it's excruciating.
Yeah.
But an ointment, being lipid-based, not only lacks those stinging preservatives, but it also creates this occlusive barrier.
Like a seal.
Yes, exactly. It traps the moisture.
Yeah.
And essentially forces the medication deeper into the tissue. It aids penetration in that localized area.
Wow.
And the clinical application is also highly regimented. You don't just, apply it whenever you feel like it.
Right. The BAD guidelines outline this really strict induction and tapering phase. It's typically applied daily for a month, then stepping down to alternate days for the second month, and eventually landing on a twice-weekly maintenance
Yeah,
dose.
that tapering is key.
While I was synthesizing the clinical protocols from Dr. Hefner and those BAD guidelines, an analogy actually came to mind. Treating lichen sclerosus seems a whole lot like fighting a house fire.
Ooh, okay. Walk me through that.
Well, the ultrapotent clobetasol ointment is basically your fire hose. Its job is to aggressively hose down the main blaze, which is the underlying autoimmune inflammation. But this intractable nocturnal itch we're focusing on, that itch acts like the smoldering embers trapped deep inside the walls.
I really like that framing. The fire hose can extinguish the visible flames, but it might not immediately reach the embers
Right, and if you don't extinguish the embers, they're eventually going to ignite the structural beams. The house is still going to burn down.
because of the damage caused by scratching.
Exactly. In this scenario, the house burning down is that permanent architectural scarring we talked about. The topical steroid is doing its job on the immune system, but patients can still find themselves completely trapped in that physical itch-scratch cycle at night.
And this is where we run into a massive hurdle when it comes to patient compliance. The Mayo Clinic forums highlight this repeatedly.
What happens?
Well, patients read the warning label on the clobetasol tube, or maybe they get warned by a general practitioner that ultra-potent steroids will thin the skin.
Right, the skin atrophy.
Yeah. So given that they're already dealing with this super fragile vulvar tissue, they understandably panic. They underdose the medication, and they leave those embers burning.
I mean, I can completely understand the hesitation. Applying the strongest steroid available to the absolute most sensitive skin on the body sounds totally counterintuitive.
It does. But the clinical consensus aggressively pushes back on this fear. That warning about skin thinning, the atrophy, that really applies to applying steroids to healthy skin.
Oh, wow. Okay.
Yeah, the context of lichen sclerosus, the disease process itself, combined with the mechanical scratching, is what's causing the thinning and the destruction. The clobetasol actually rescues the tissue.
By shutting down the inflammation.
Right, it shuts down the inflammatory cytokines that are degrading the tissue. It's a critical paradigm shift for the patient. The medication is the shield. It's not the weapon.
That is such a good way to put it. But even with perfect compliance to the topical regimen, we kind of arrive right back at our core problem. The underlying inflammation is being managed, yet the nocturnal urge to scratch persists. It keeps the patient awake and puts the tissue at risk.
Yeah, the embers are still hot.
Exactly. Which brings us to the first escalation. How do specialists physically stop a patient from tearing at their skin at 3:00 a.m. when the topical approach just isn't enough?
Well, the answer in the protocols is fascinating. They turn to sedating oral antihistamine.
Right. The clinical notes specifically point to older first-generation antihistamines. We
Yeah.
frequently see hydroxyzine prescribed at 10 to 50 milligrams a day, or diphenhydramine, which most people know as Benadryl, at 25 to 50 milligrams.
Yes.
Okay, let's unpack this. LS isn't an allergic reaction, so why are we using antihistamines? Looking at the pathology, it seems entirely contradictory. LS is an autoimmune condition. It's not an allergic reaction. We aren't dealing with a massive histamine release like you would with a peanut allergy or a bee sting. So why are specialists deploying histamine blockers to fight an autoimmune flare?
You've hit on the exact paradox. And the answer is, they aren't prescribing these medications for their primary mechanism of action.
Wait, really?
Yeah, the goal is not histamine blockade. Specialists are actively utilizing the primary adverse effect of these first-generation drugs.
The side effect.
Exactly. Unlike modern allergy meds, these older drugs readily cross the blood-brain barrier and they depress the central nervous system.
So they are literally weaponizing the drowsiness.
Yes, it is a totally calculated medical maneuver. The objective is to forcefully induce a sleep state so deep and so heavy that it physically incapacitates the patient's nocturnal urge to scratch.
Wow.
By artificially sedating the patient, you sever the physical action of the itch-scratch cycle. You protect the skin while the clobetasol does its slower underlying work.
We see the reality of this approach playing out in those Mayo Clinic Connect patient forums. Reading through those threads, you realize the sheer level of desperation these patients face before finding this strategy.
It's heartbreaking, really.
It is. One specific patient detailed their regimen of taking 25 milligrams of hydroxyzine nightly. And they said it was the only thing that successfully suppressed the nocturnal itch and allowed them to actually sleep without waking up to new tissue damage.
That makes total sense. But, Dr. Melissa Dahir's clinical notes emphasize that timing this intervention is highly delicate.
Right, because pharmacokinetics become the primary challenge here.
Exactly. Her protocol dictates that these heavily sedating medications need to be taken in the early evening, usually roughly 1 to 2 hours before bedtime.
Because if a patient waits until the itch wakes them up at like 1:00 a.m. to take the hydroxyzine, the half-life of the drug guarantees they're going to be navigating a severe cognitive fog the entire next day. They'll be a zombie.
Oh, absolutely. You have to time the ingestion so the peak plasma concentration aligns with the natural spike in nocturnal itching. But you also have to allow enough time for the drug to clear the system before morning.
It's a total tightrope walk, but let's escalate again. What happens when the embers are burning so hot that the itch cuts right through the central nervous system depression?
It does happen.
Right. If the hydroxyzine isn't enough to keep them sedated because the sensation is just too agonizing, where does a specialist go next?
When sedation fails, the strategy has to pivot. We move away from trying to artificially induce sleep, and we move toward aggressively intercepting the signals themselves at the nerve level.
We attack the communication lines.
Exactly.
I'm looking at the local interventions first here. The clinical protocols recommend topical numbing agents, specifically topical xylocaine 5%, applied directly to the vulva up to 4 to 6 times a day.
Right. And what's happening pharmacologically there is that the xylocaine is inhibiting the voltage-gated sodium channels in the local nerve endings.
Okay, what does that actually mean?
It basically prevents those nerves from physically generating and conducting the electrical impulses that the brain interprets as pain or severe itch.
That is so interesting. And the Mayo Clinic forums actually gave us a fascinating real-world look at how patients optimize this.
Oh, what did they do?
One patient shared that they use a specially compounded prescription cream. So they actually have a compounding pharmacy mix, 5% to 6% lidocaine, directly into Aquaphor ointment.
Oh, wow.
Yeah, and they apply this highly occlusive numbing barrier every 3 hours during a severe flare.
Notice the brilliance of that specific combination.
Right.
They're utilizing the lidocaine to shut down the sodium channels while using the heavy lipid-rich Aquaphor to form a physical protective barrier over the erosions.
So it keeps the medication exactly where it's needed most without stinging?
Yes, it tackles the surface sensation beautifully.
Hmm.
But, specialists don't just stop at the surface. They intercept these signals systemically, too.
Right. The sources show medications like amitriptyline, usually a 25 milligram dose at bedtime, or gabapentin being brought into the mix. But I have to ask, I know amitriptyline is a tricyclic antidepressant. It's often used off-label for neuropathic conditions like sciatica.
Yeah.
What is an antidepressant doing in a protocol for an autoimmune skin condition?
What's fascinating here is, to understand that, we have to look at how chronic inflammation permanently alters local biology.
Okay.
When vulvar tissue is subjected to chronic unmanaged inflammation and the constant mechanical trauma of scratching over and over, the local peripheral nerve endings become permanently sensitized.
Wait, so they undergo a physical change?
Yes, they're bombarded by inflammatory cytokines for so long that their baseline threshold just drops. They become hyperreactive.
Like they're on a hair trigger.
Exactly. They begin firing itch and pain signals continuously, even when the initial inflammatory trigger is temporarily subdued. The itch actually transitions from being a purely dermatological symptom to a neurological one.
Oh, wow. So the disease evolves.
It does. While the topical lidocaine provides a localized blockade, neuromodulators like amitriptyline act as a system-wide dampener. They calm that hyperactive nervous system from the inside out, raising the threshold back up so those sensitized nerves stop misfiring.
So you're basically fighting a two-front war, numbing the surface receptors while simultaneously quieting the internal nervous system wiring.
That's a great way to describe it.
It really highlights just how complex the pathophysiology of this disease becomes if it's left unchecked. But I want to push this escalation ladder to its absolute limit.
Let's do it.
Let's assume the worst-case scenario. A patient is utilizing the ultra-potent clobetasol. They're taking hydroxyzine to induce sleep. They are applying lidocaine compounds every 3 hours, and they're taking amitriptyline at night.
That's a heavy regimen.
Very heavy, and yet they are still locked in an extreme, agonizing flare-up. They are physically and mentally just at their breaking point. What is the ultimate emergency brake in these protocols?
When a patient is trapped in an unbreakable flare-up of that magnitude, Specialists deploy what we can accurately call systemic circuit breakers.
Circuit breakers, okay.
Dr. Hope Hafner's protocol outlines this intensive 8-step itch, scratch, itch regimen that is specifically designed for this kind of crisis. And the cornerstone of this emergency intervention relies on systemic steroids.
Wait, wait. Earlier, we established that the guidelines heavily stress applying steroids topically to target the skin directly to avoid side effects.
Right.
Why are we suddenly having patients swallow high-dose prednisone pills or get intramuscular triamcinolone injections?
I get it. Your skepticism is entirely justified here. But the distinction in the clinical literature is absolutely crucial. Systemic steroids, the pills or the injections, are never, under any circumstances, prescribed for the long-term maintenance of lichen sclerosus.
Okay.
The side effect profile for long-term use is simply too dangerous. However, in this specific crisis scenario, they are deployed as a rapid, temporary system override.
So it's basically a blunt force instrument.
Precisely. When the local inflammation and the resulting hyperreactive itch are completely out of control, the topical clobetasol sometimes just cannot penetrate deeply enough or act quickly enough to break the cycle.
The tissue is just too inflamed.
Exactly. So a short, aggressive burst of systemic steroids. Dr. Hafner suggests a taper like 40 milligrams of prednisone for 5 days, stepping down to 20 milligrams for the next 10 days. It floods the entire body.
Wow.
It forcefully shuts down the runaway immune response from the inside, dropping the inflammation to a manageable baseline.
Yeah.
And once that acute fire is suppressed, the systemic drugs are withdrawn, and the patient is immediately transitioned back to the topical clobetasol to maintain control.
Ah, okay. So it's the heavy artillery clearing the battlefield so the infantry can move back in and hold the line.
That's exactly it. And alongside that pharmacological barrage, the protocols also emphasize really basic physical interventions. Things as simple as applying cool gel packs or cold compresses to the vulva.
Just to physically cool it down.
Yeah, the localized vasoconstriction and the physical cooling of the nerve endings, it really helps strip away the heat and the swelling that drive that acute sensation.
That makes a lot of sense. But there is one final intervention on this escalation ladder that honestly, genuinely gave me pause.
Oh, what was that?
I was reading through the British Association for Sexual Health and HIV guidelines, the BSHH guidelines, and right there, in the Management Tools for Persistent Itch, they list cognitive behavioral therapy, CBT.
Yes.
I have to push back on this. If we just spent the last 15 minutes establishing that unconscious scratching causes literal architectural destruction of the vulva, how is talking about your feelings going to stop physical micro-tears?
It's a completely common reaction. Many patients feel, dismissed or even gaslit when therapy is suggested. They interpret it as the specialist saying the itch is all in their head.
Right, which is insulting when you're in agony.
Very.
Yeah.
But the clinical rationale for CBT in this context is actually deeply rooted in neuroplasticity.
Okay, explain how neuroplasticity factors into a skin disease.
Well, when a patient suffers from chronic, unrelenting itch for months or years, the brain physically rewires itself. A subconscious, automatic neural loop gets constructed.
A loop?
Yeah. A physical sensation occurs, and the brain's immediate, hardwired reflex is to initiate scratching, associating that physical action with temporary survival or relief. The itch is entirely real, but the behavioral response becomes conditioned.
Wow.
So CBT is not prescribed to manage the emotional distress, though obviously that is a massive benefit. It's deployed to physically unlearn that subconscious behavioral urge.
So it provides the cognitive tools to interrupt the automatic reflex before the hand even moves to the skin.
Yes, it is an active intervention to rewrite the brain's neural pathways, decoupling the physical sensation from the conditioned physical response.
That is wild. When you look at the entire scope of what we've covered, the sheer depth of this medical escalation ladder is just staggering.
It really is.
For anyone dealing with the nightmare of severe nocturnal itching from lichen sclerosus, specialists do not just throw up their hands. It starts with the foundation, right? Aggressive, ultra-potent topical clobetasol to suppress the underlying autoimmune inflammation and halt the tissue degradation.
Right.
And if the physical urge to scratch at night breaks through, they deploy sedation, utilizing older antihistamines like hydroxyzine to forcefully induce sleep.
Severing that cycle.
Exactly. If the pain and itch signals are too intense, they attack the nervous system directly. They utilize local sodium channel blockers like lidocaine and systemic neuromodulators like amitriptyline to quiet those hyperreactive nerves.
Yes.
And for the absolute worst case scenarios, they pull the emergency brake with oral prednisone tapers to crush the immune response while integrating cognitive behavioral therapy to undo the neurological conditioning caused by chronic suffering.
It really is a comprehensive, multidisciplinary approach to preserving the patient's anatomy and ultimately their quality of life.
It is. And to you, the listener, I really want to leave you with a very clear message. If you, or maybe someone you love, is suffering in silence from this specific condition, or frankly, from any chronic physical symptom that is destroying your sleep and your daily life, just enduring it is never the medical answer.
Never.
If your current medical provider tells you there is nothing else to be done, you need to know that there is almost always another rung on the medical ladder. Advocate for yourself. Seek out the specialists who actually understand these specific protocols. The options exist.
And, the persistence required to find that relief, it can be exhausting. But the escalation ladders are there. And exploring this really intense intersection of dermatology, neurology, and psychology brings up a profound, broader implication.
Oh, like what?
We've just analyzed how a localized autoimmune skin condition can physically rewire the brain's neural networks, right? To the point where it necessitates psychiatric behavioral therapies to prevent anatomical destruction.
Yeah, the CBT.
It forces us to ask a much larger question about modern medicine. As global rates of chronic inflammatory diseases just continue to rise, are purely pharmaceutical, specialized models of care becoming obsolete?
Oh, wow.
If the brain and the skin are this deeply entangled in a continuous feedback loop, perhaps the future of treating chronic physical illness doesn't lie in just finding a stronger topical cream.
Right.
Perhaps the next great medical paradigm shift requires us to treat the brain-skin axis as a single, unified organ system where psychology and dermatology are no longer separate fields, but two sides of the exact same cure.
That is a complete rethinking of how we define and treat physical disease. It is a brilliant concept to chew on. So the next time you find yourself awake in the silence of the night, battling a symptom that refuses to be ignored, remember the sheer depth of the medical arsenal out there. You aren't fighting it alone, and there's always a next step to take.